2021 Wellness Retreat is an opportunity for clinicians and non-clinicians to enjoy fall in Tennessee and maybe even a leaf change while you take a deep dive into learning about the mind-body connection and strategies for improving your overall well-being. Up to 21 CEUs will be available for clinicians, but again, you don't need to be a clinician to attend. The retreat is being held October 20th through 23rd at Cumberland Mountain State Park and is limited to 60 people to allow me to have plenty of time to interact with everyone. Go to allceus.com/wellness to see the detailed schedule and download the registration form. I look forward to seeing you. I'd like to welcome everybody to today's presentation on Tip 51, or Treatment Improvement Protocol 51, by the Substance Abuse and Mental Health Services Administration, or SAMHSA, talking about the specific needs of women in substance abuse and co-occurring disorders treatment. I'm your host, Dr. Dawn-Elise Snipes. Now, obviously, in an hour, we can't go over everything that's in the tip. If you want to read the entire tip, it is available on the SAMHSA website for free as a downloadable PDF. There are some good nuggets in there. It was published back in 2015, but unfortunately, they still use a lot of, it feels like, that they're using a lot of very stereotypical gender roles. So to that end, I didn't like it. But the information that was contained within was helpful. We just have to kind of shift our perspective a little bit. And we'll talk about that today. We're going to talk about how the needs of men and women may differ, and specifically people who are biologically men versus biologically women, because there are some physiological differences. We'll discuss conditions that are more typically diagnosed in people who are biologically female and highlight changes that can be made to increase access, engagement, and retention of people who identify as women in treatment. This presentation is based on SAMHSA Tip 51, which was written in 2015. Much of the information is still good. However, throughout the presentation, I have modified the language some. Generally, I'm going to try to adhere to referring to people who are biologically female as women, or people who identify as female, and people who can be of either biological gender but embrace the role of primary caregiver are referred to as primary caregivers. I took great issue with some of the points in this tip because it felt like the assumption was women are always the primary caregivers for young children, and that's just not the case. So some of those issues that we're going to talk about apply to people regardless of gender or gender identification if they are primary caregivers. Okay, that was my diatribe. 6.2 females over the age of 12 in the U.S. have a substance use disorder. Now, this was measured based on the biological gender. Anorexia was only associated with oppositional defiant disorder and not other psychiatric diagnoses. So that's kind of interesting to note that anorexia or eating disorders, which kind of fall under that rubric for co-occurring issues, is generally, or at least at that point, was only associated with ODD. Eating disorders among adolescents was often associated with functional impairment and suicidality. Binge eating and bulimia were associated with more suicide attempts. So it's important to recognize that food pathologies can co-occur with oppositional, defiant, depressive disorders and other conditions. Women who have different physical responses to substances. People who are biologically female may be impacted by a smaller quantity of substances. Women with substance use disorders have greater susceptibility to, as well as earlier onset of, serious medical problems and disorders. So they may have more problems at smaller doses and start having more difficulties in less time. So it may only take, a month for example, and I'm just kind of pulling numbers out of the air, for a woman to start having significant impacts of alcohol misuse on her liver, whereas a adult male may be much larger and have different body mass percentages and may not be affected as quickly as a result. In people who are biologically female, pregnancy is a significant concern when we're talking about addictions and eating disorders. Addictions and eating disorders, because addictions obviously expose the fetus to substances, and eating disorders can deprive the fetus of essential nutrients. People who abuse substances are more likely than other people to have co-occurring disorders. Generally, and if you've worked with people in substance use treatment, you recognize that the majority of people with substance use or addiction issues also have some co-occurring other stuff. It can be major depression, it can be generalized anxiety, social anxiety, ADHD, personality disorders, or even adjustment disorder. But generally, there is some stuff going on that needs to be addressed concurrently. Because if they get clean, well, that's great. But if they get clean and they're still clinically depressed, and one of the reasons they were using was to get some relief from that clinical depression, then guess what? They're probably not going to stay clean for very long unless we're also concurrently treating the depression. Likewise, we can't effectively go in and just start treating the depression and go, oh, that substance use thing or addiction will spontaneously remit as soon as they feel better, because the addictive behaviors and or substances are altering the person's neurochemistry. So as long as they're continuing to monkey with that neurochemistry through the addiction, their maximal gains in treatment for their mental health issue are probably not going to be reached. People who have substance use disorders are more likely to have been physically or sexually traumatized and subjected to interpersonal violence. Now, I know this is the presentation on particular issues for women in substance use and co-occurring disorders treatment, but this statement is true. People, regardless of gender, who have addiction issues are more likely to have been exposed to trauma. Significant relationships and a family history play an integral role in the initiation, pattern of use, and continuation of substance abuse. We know this is true for everybody. People's environment contributes to how they learn to cope. It contributes to the availability of substances. It contributes to the attitude about substances. If they grow up in a family in which substances are used or at least not shunned, then they're going to have a more positive attitude towards substances than somebody who grows up in an environment where substances are treated as something that you shouldn't use. From a sociocultural perspective, women and those who identify as women tend to define themselves in terms of their webs of social relationships. People who embrace a more traditionally female gender role. And I'm not sure if I'm saying this right, so I'm trying not to, offend people. But, people who embrace a traditionally female gender role, regardless of their biological gender, often tend to embrace an attitude of compassion and cooperation, and are more involved in interdependent relationships than people who embrace a traditionally male gender role. Women are more likely to be introduced to and initiate alcohol and drug use through significant relationships, including partners and family members. A lot of times, what we're looking at, not so much gender, biological gender specifically, but we're looking at people who are very committed to their relationships and tend to make decisions based on what is going to keep the peace in this relationship. So they may be more likely to be persuaded to use. If it is something that their significant others are engaging in, they may be more motivated to experiment. Significant relationships and other adult family members may substantially influence and impact people's behavior associated with treatment seeking, support for recovery, and relapse. Well, this is true, again, regardless of gender. We do want to recognize this, that if you are in a family or in an environment that is pro-treatment, that says, yes, you need to stop doing this, it is ruining your life, you need to go get help, that's a whole different ball game than a family that minimizes what's going on, says this is just a choice, you just need to stop, make a decision that you're not going to do it. The sort of the moral choice model versus the disease model. If they're supportive of recovery, and we'll talk about this in caregivers when we get down to caregivers in just a second. But when they go into treatment, especially if it's residential, they are not around to cook meals. They're not around to pay bills. They're not around to go to work. They're not around to take care of kids or dogs or whatever else. So if the other people in the immediate family are not willing to help out, it makes it a lot more difficult. Treatment's expensive. If the other people in the family are not willing or agreeable, if the person doesn't have their own money somewhere, if it's mutual money, then it also may be difficult to maintain that. And Gwen's very right. A lot of relationships, substance abuse and addiction, not just substances, but any addiction, is a family disease. And the family is organized around the identified patient. They're organized around enabling the addiction. They're organized around the different family roles. You have your hero, your mascot, your scapegoat, etc., a whole different class. But it's true that when a person with an addiction goes into recovery, it upsets the apple cart. It changes the dynamics of the family. It also requires, in many instances, if not all, it requires that people in the family acknowledge their own stuff, because they can't say it's that person's fault anymore. Once that person is in recovery and doing the next right thing, then they've got to start, getting on board, which means they've got to change and they have to address their stuff. Not only their anger and resentment and guilt and all that other stuff that surrounds the identified patient, but anything else that they were avoiding or blaming the identified patient for. So there's a lot of murkiness that happens when people enter treatment. Women, primary caregivers, may have less support from family or partners than do men for seeking treatment. This could be because in some cases it's seen as a choice, but a lot of times it's seen as too much of an imposition on the family for the primary caregiver to go into treatment. For primary caregivers, pregnancy, parenting, and childcare influence alcohol and drug consumption. Now, obviously, we're talking about, in terms of pregnancy, people who can get pregnant, but parenting and childcare influence alcohol and drug consumption for either gender. If they are a primary caregiver and they're home all day with a 2-year-old, you can start really craving somebody who speaks in full sentences. If there's a lot of stress, if it's a high needs child, if it is a colicky baby, there's a lot of, if the baby may be great, or infant, child, whatever, may be awesome, but the person themselves may have pre-existing mental health issues that make it difficult to cope. Or a person, and this can happen for either biological gender, may develop postpartum depression. And Yes, I'm saying that right. Men can develop postpartum depression, even though they're not the birth parent. There are alterations in testosterone levels when a new baby is brought into the house that can contribute. So again, I've got a video on postpartum depression on the YouTube channel that you can watch later if you're interested in that. However, getting back to this one, we need to recognize that when somebody's a primary caregiver, they're taking all of this to heart and they're weighing, can I make time to go to treatment? They're also, if they've got parenting and childcare duties, if they're really busy a lot of the time, they may not be using as much. But if they are locked down a lot of the time, if they're at home by themselves, like we were during 2020, won't say the C word, there can be an increase in substance use. And we did see some of that in 2020. So we want to recognize that primary caregiving not only influences substance use levels, but also people's willingness and ability to engage in treatment. Primary caregivers are much more likely to enter treatment if it affects child custody. So it's important to put that out there. If they are getting divorced, for example, and their substance use comes to the forefront, or if for some reason they end up in the crosshairs of Child Protective Services, then they're probably going to be much more motivated to go to treatment because they have a case plan, because they have a reason that they need to go through and do this. Now, that's not the ideal way. I would love to say that I would love for more resources to be available for people before they get to this point. I have worked in dependency drug courts that are very effective, but that is sort of your latch ditch effort. In dependency drug court, the person is enrolled, and if they test, and they've got a case plan with Child Protective Services, they're also being supervised by the courts. If they test dirty for their substance, then they end up going to jail for some amount of time, depending on if it's first offense, second, or third. But if they fail out of the program, if the judge and the treatment team recommend that they be discharged from the program, then in most cases, it results in a permanent termination of parental rights. That's a big deal. So, there's a lot of teeth, if you will, behind some of these drug court issues and custody issues. We don't want to use that to coerce people into treatment when at all possible. But we do want to recognize that sometimes that can help, as we say in substance abuse treatment, raise their bottom. If people are able to have their children in treatment, primary caregivers are more likely to enter, participate, stay in the program, and maintain abstinence. When I was running the residential treatment programs, one of our programs was a mother-baby unit. And I use the term baby kind of loosely because it was children up to the age of 2. We had the ability, the capacity to let moms have their child or children room in with them during the treatment process. So they didn't have to try to find somebody to care for their child while they were in a treatment program. So that can be really helpful. Now, other programs I've read about in recent years are able to accept children up to, much older ages. And I think that's awesome. Our program, like I said, was only able to do up to 2. But it is important to recognize that lack of a safe place for children to be placed while the primary caregiver is in treatment is a huge barrier to entering and completing treatment. With intensive outpatient, similar things apply. Yes, They're only in treatment for 3-5 hours a day. However, if they don't have childcare, if the child is too young to be going to Head Start or pre-K and they can't afford childcare, then a lot of times they're not able to effectively access treatment unless there is some sort of child care program provided by the agency or some sort of subsidized child care provided by the county, the state, what have you. Unique roles. People who identify as women are more likely to encounter obstacles across the continuum of care as a result of gender expectations and socioeconomic hardships. Unfortunately, even in 2021, there are still a lot of very traditional gender role expectations, and that is not effective in a culture where we have a much more fluid definition of gender, so gender identity. So it's really important to recognize that even since this was published in 2015, there are more confounding issues for people entering treatment, because not everybody who identifies as a woman is biologically female. Yet they would probably be more appropriately suited to a women's program. So we need to consider, exactly what are we communicating when we create treatment programs that are unigender, so to speak, and are we inadvertently discriminating against people who would benefit? Are we in our treatment programs promoting stereotypical gender expectations which the people may not embrace anymore? And if so, we need to be sensitive to cultural differences and really take a look at that. Socioeconomic hardships can also be challenging. Now, this is more particularly in our culture for people who are biologically women. We know that there is a pay disparity for women in the workplace. So that can also contribute to challenges. Women with substance use disorders have enhanced treatment needs related to pregnancy. Now, this is obviously for people who are biologically female. If they are pregnant, they have enhanced treatment needs to help them detox safely, if possible. Not all medications are safe to detox from completely when you are pregnant, which is why a lot of women end up staying on methadone, for example, until they deliver. So it's important that the addiction treatment provider is aware of the person's pregnancy and is aware of what's going on. Additionally, and this is so challenging when working with people who are pregnant, a lot of the psychotropic medications, especially your mood stabilizers and antipsychotics, are not recommended for consumption during pregnancy. So it was not unusual for us to have people on the unit who were pregnant and unmedicated. So in addition to the normal hormone shifts that happen with pregnancy and pain and difficulty sleeping and altering of circadian rhythms and everything else that can make pregnancy challenging for people, some of the people also were unmedicated and were in active manic or depressive episodes. They were having, other issues that we were having to try to manage as well as possible without their medications of choice, per our attending physicians. So that is a huge issue. If they are not in residential, think about how challenging or how dangerous this could potentially be if you have someone who is, for example, has bipolar disorder, is pregnant, and is taken off their mood stabilizers during their pregnancy in order to keep the baby safe. A lot of people, even people who are on your stereotypical SSRIs, are also taken off those medications when they are in their first 2 trimesters. And it can be really challenging for the individual. It can also be really challenging for their family because they've got a person whose mental health issues are no longer stable. So we need to, as clinicians, really get in there and say, what can we do to enhance your support during this process so A, you don't relapse on substances, and B, we can help you manage to the best extent possible your mental health diagnoses and keep everybody, the identified patient, the individual, as well as the family safe. Primary caregivers also have enhanced treatment needs related to care of children and other caregiver roles. It's important to consider the impact of what's going on, any guilt they may have if they're not able to take care of their children, any issues they may have if the child, for example, is in a relative placement and starts having problems in school. That can pull at the patient's attention or motivation, and they may end up discharging from treatment if they are concerned about their child's welfare. Overall, women and people who identify as women report more interpersonal related stress in relation to negative affect, whereas people who identify as men report more legal and work-related stressful life events. So what we're saying here is a lot of the interpersonal stress for people who identify as women revolves around their negative affect, their depression, their anxiety, their stress levels. Lots of cognitive behavioral tools can be super helpful here. It's not going to do everything. We need to remember that symptoms of mood disorders are the result of alterations in brain chemistry. And we need to ask why. What is altering this person's brain chemistry? Is it chronic stress? Is it a history of trauma? Is it genetics? Is it nutrition? Is it lack of quality sleep and altered circadian rhythms? Is it lack of sufficient estrogen or testosterone? There's lots of reasons, but we need to explore why this might be going on for this particular individual at this time. In order to improve their affect, since that seems to be a major relapse trigger. In terms of people who identify as men, more legal and work-related stressful life events. Now, I don't know if that's still true in 2021 because we have a lot of people who identify as women who are primary breadwinners. So, yeah, I don't know. We want to ask people. We don't want to assume that because of their gender or their gender identity that X is a particular stressor versus Y. We want to ask them, what are your main sources of stress? Pretty straightforward question. Risk factors for substance misuse and the development of addiction include familial substance abuse. If people are actively using around the person when they're growing up, then that behavior is normalized and is maybe even modeled as a coping strategy. A family of origin that is chaotic, argumentative, blame-oriented, or violent can be also very damaging and a high risk factor. And if we look back at adverse childhood experiences, environments in which there are caregivers with mental health or addiction issues, that qualifies as an adverse childhood experience. So if you extrapolate, a lot of times, if the environment is chaotic, argumentative, blame-oriented, and violent, there's probably one or more people in that household that have either a mental health or an addiction issue or both. In families where people grow up being expected to take on adult responsibilities as children, including household duties, parenting of younger children, and emotional support of parents. That's a huge risk factor for the development of substance abuse and mental health disorders later in life. Children are not equipped to cope with the demands of adulthood. So if they're thrust into that role where they're having to be the caregiver, if the boundaries just completely flip, it's very confusing. It's very exhausting. A lot of children that grow up in these environments develop a sense of depression and helplessness, as well as anger and resentment that need to be dealt with. Technically, being single or divorced may be a risk factor. Approximately 11% of divorced or separated women and 16% of women who've never been married between the ages of 18 and 49 abuse or are dependent on alcohol or an illicit drug, compared to only 4% of married women. That's just one of those stats that's thrown out there. Again, that one in particular, they actually drew from a study in 2004. And our culture has changed a fair amount now. So it's important not to take this as the be-all, end-all truth. It's important to recognize that back in 2004, the statistics seem to show this. However, in modern culture, we've also seen a exodus, if you will, from the idea, I guess exodus isn't the right word, but a lot of people who are in my children's generations are rejecting marriage. So I'm not sure what these stats would look like today. We do want to explore why that might be. Why in 2004 being single or divorced might have increased substance misuse. My hypothesis is when people are single, they tend to go to a lot of people, not all, tend to go to more parties, may go to more bars, may be exposed to more substances. People who are divorced, well, they're single again. So they may also be trying to meet other adults. And it's especially after you get out of college, it's really hard to find other adults except for the people that you work with or your neighbors. So they may tend to frequent places where there's more substance use. And people who are divorced may go, if the divorce is unpleasant, may end up starting to use substances to help them cope with the stress of the divorce. Whereas people who are married may have more social support, may have other things going on that buffer them from substance misuse. However, if their partner uses substances and they're married, they're at a greater risk because of, like we said earlier, a lot of times we bring the people that we love on the ride with us, whatever that ride might be. A lot of times we can pull people into our vortex. And so if they are involved with somebody who's in a negative space, then the partner may also pull them into a negative space. Personal characteristics that put them at high risk for substance misuse and mood disorders. Poor self-image. Well, that can lead to high levels of anxiety that people might want to self-medicate. It can lead to withdrawal and self-medication of, feelings of abandonment and isolation. There's a lot of it. High anxiety, difficulty with self-soothing, sensation seeking, someone who is crisis or drama prone. And I don't mean that as a criticism. There are people, and I had one client I can remember in particular. It was basically her alternate addiction. When she was not able to access her substance of choice, she would get into everybody else's business in the house and stir up drama. And it was like clockwork. We could predict this with this particular client. And, I've seen it in others, but it was very prominent with her. So it's not a criticism. It's a recognition that sensation seeking, remember, behavior equals communication. When people are doing this, what are they doing? For her, we determined, and no surprise, that by stirring up drama, it kept her from having to look at her stuff. We were so busy trying to keep other people from discharging and, all the other stuff that comes along with drama in a residential program, that she wasn't being held to task as much on her assignments and going to group and those sorts of things. Same thing with people who are crisis prone. If the crisis can divert your attention from something they don't want to talk about, something that's painful or scary, to something else, then it works for them. So people who are drama or crisis prone, these behaviors often work in a pseudo self-protective capacity. However, it also means that they have stuff that they're avoiding or don't feel like they have the ability to cope with. They dysregulate easily, which makes them more at risk for trying to self-medicate and self-soothe with addictive behaviors. Depressive features, again, self-medication, and childhood trauma, where someone might want to try to numb their pain. They may use substances in order to feel more sociable because they have a poor self-esteem, or they may use substances to help them stay more vigilant, believe it or not. Some people will use stimulants to help them stay more awake and more vigilant for what's going on. And it is important to recognize that a lot of people learn their behaviors from the environments in which they grew up. If you grew up in a behavior where people coped with using substances, guess what? You probably, are going to model that. If you grew up in an environment where people had one or more persons in the environment exhibited borderline type behaviors or antisocial type behaviors when they were experiencing stress or fear, guess what? That's probably going to be one of the go-to skills of the individual as they grow up, because we're not born knowing how to cope with life. We learn it from our caregivers. And if our caregivers are unable to teach us healthy coping skills, we take what we can get. And it's normal to a lot of people who grow up in dysfunctional environments. They think those behaviors are what everybody does. So, there is a process and a period where those people have to become aware that, okay, maybe this isn't the best way, or maybe there's an alternate way. Drugs of choice. Women are significantly more likely to use and abuse prescription medications, including anxiolytics, your anti-anxiety medications, and narcotics, opioids, than are men. And a lot of there have been studies that have been done that have that have found that women tend to present a lot more frequently and be diagnosed a lot more frequently with anxiety-related disorders. So guess what? They're getting those prescriptions a lot more. And they tend to present with more pain-related complaints and autoimmune disorders. Autoimmune has inflammation. Inflammation means pain. Think about lupus. Think about fibromyalgia. There's a lot of things in autoimmune conditions, Crohn's disease, that cause a lot of pain. And those are more common in women as well. So they are being prescribed these medications more, which means it's easier for them to access them. They're like, hey, all I have to do is call in for a refill and bada bing. So that's something else that we need to look at from a multidisciplinary perspective. Not saying that some people don't need these medications at certain points, but hopefully they're developing more alternatives that are less addictive. Conditions more common in people who are biologically female. Well, pregnancy, duh. And pregnancy alters hormones. Pregnancy can be really challenging for some people, especially if they have to go unmedicated, which can set them up to even develop a substance use disorder, even if they didn't have one prior to pregnancy. PMDD, premenstrual dysphoric disorder. As hormones change, some people are more sensitive to those hormone fluctuations. Some people have larger hormone fluctuations. And hormones, if you remember the presentation on the hypothalamic gonadal, pituitary gonadal axis, the HPG axis, our gonadal hormones influence the availability of norepinephrine, serotonin, and dopamine. So if people's hormones are going like this, guess what? Serotonin, norepinephrine, and dopamine are kind of following along as appropriate for the particular neurotransmitter. So we need to recognize this is not drama. This is an actual physiological difference between some people. Polycystic ovarian syndrome has actually been related recently to chronic stress, but obviously, it involves gonadal hormone levels, and people with polycystic ovarian syndrome often experience clinical depression, weight gain, hair loss, acne, and a lot of facial hair growth, which can be exhausting for people. It can really take a toll on their self-esteem because they don't fit the image of what mainstream media tells them they're supposed to look like. Plus, the depression can be extreme at times. And people with polycystic ovarian syndrome also have a really hard time getting and or staying pregnant, which can be a big issue for some people. It's important to recognize this because all of the challenges that go along with PCOS can contribute to somebody being vulnerable to substance misuse for comfort, for self-medication, because especially if it's not adequately treated or diagnosed, they may feel invalidated, misunderstood, and helpless. Menopause. Again, we have an alteration of those gonadal hormones that can contribute to increased mental health symptoms or mental illness symptoms, which can trigger a relapse in people who have a history of substance abuse, or in some cases, it may trigger pathological use. Migraines are a lot more common in women. 18% of women report migraines, whereas only 3% of men report migraines. Migraines hurt. Migraines are debilitating. It's not just I've got a stress headache. That you get nauseous, light sensitivity. There's lots of things that go along with migraines. And they have found some association of migraines with migraines to neurotransmitter levels. But we want to recognize that this is another one of those things that people may self-medicate. Hypertension after age 50 is more common in women. Now, that's more of a be on the lookout than a causative factor. But we want to recognize that people who drink a lot of alcohol, for example, if they're heavy substance users, alcohol can exacerbate hypertension. So being aware of that. Rheumatoid arthritis is autoimmune. And lupus are both autoimmune. So those can cause increases in pain. They can cause self-medication. They can cause social withdrawal, especially during flare-ups. So there can be self-medication. There also can, of the pain, there can also be self-medication of the depression and helplessness that may be associated with it. Helping people develop strategies to manage their flare-ups is essential. Irritable bowel syndrome, more common in women. We've talked before about how the gut microbiome influences levels of all of our neurotransmitters, but specifically serotonin, and some of our gonadal hormones. So if the bowel is dysfunctional, if the bowel microbiome is out of whack, a lot of times it can contribute to systemic inflammation, contribute to pain, as well as neurotransmitter imbalances that, again, can trigger mental health issues as well as addiction relapses. 90% of people with fibromyalgia are women. 10% are men. Fibromyalgia is another autoimmune issue. It's important to recognize that it is a neurochemical disease, and people with fibromyalgia show a higher than average amount of substance P, a neurotransmitter that signals pain, and a lower than average amount of serotonin, a neurotransmitter that inhibits pain. So just kind of bear that in mind. Fibromyalgia is real. There are alterations in body chemistry in people with fibromyalgia that makes them experience more pain. Barriers to treatment: intrapersonal, individual factors including health problems, psychological issues, cognitive functioning, motivational status, and treatment readiness can be barriers to treatment. So let's go back to the beginning, looking at your treatment program. What health problems can you handle? In our residential program, we were a level 3.5, which meant that people had to be medically stable in order to be admitted. So if they had conditions that were still being stabilized, like hepatitis or cirrhosis or Korsakoff's or Alzheimer's, we could not handle them at our level of care. So that can cut out a lot of treatment program availability. People who have health problems that prevent them from getting to intensive outpatient 3 to 5 days a week, that can also be an issue. Same thing with psychological issues. If they're depressed, if they have anxiety levels, if for some reason they can't drive, if they have obsessive compulsive disorder. I had one client who regularly couldn't get to treatment because he would be going through his ritual. He would make a mistake and he'd have to start all over again. And he'd end up in this loop for the day. And it was very challenging for him. So it's important to recognize that there are issues that need to be considered. If you're working with co-occurring disorders, how can you accommodate people with social anxiety? How can you accommodate people with post-traumatic stress disorder? How can you make the environment trauma-informed so they feel safe and empowered? If they're having difficulty with cognitive functioning, as a lot of people do in early recovery, because they're still getting out of the fog, so to speak, and once they get out of the fog, they've got so much stuff on their plate, it can feel overwhelming and they may have difficulty concentrating and focusing. So we do want to focus on what can we do to accommodate people during this process, writing things down, going slowly, taking frequent breaks to give people time to process information if you're doing groups, for example, having shorter individual sessions if that's what you're doing. Their motivational status may change. They may get into treatment and they may be gung-ho. It's, let's go, let's do this. I want to feel better. And a week in, it starts to get really freaking uncomfortable. And, because you're getting to stuff, so to speak. And a lot of times we will see people backslide in their motivation back to that pre-contemplation or contemplation stage where they're like, you know what? I was wrong. My issue really wasn't that bad. I'm definitely not as bad off as Jim Bob over here. So peace out. We want to make sure that we are regularly, every group if possible, every interaction if possible, doing what we can to enhance and maintain motivation. And treatment readiness. not everybody's ready for treatment. Interpersonal, relational issues, including significant relationships. Are they getting support or not from their significant other? Family dynamics and support systems. Who's letting their dog out? Who's making sure that their house doesn't flood? There are a lot of things that people have to take care of before they can go into residential treatment. There are a lot of things that people have to take care of if they need to be transported, or if they need to be in, even if they can transport themselves, treatment 5 days a week for 4 hours. They may not be able to do the same things they used to. Structural barriers, including program characteristics like policies, procedures, program designs, and treatment restrictions. So we want to go back up to, especially intrapersonal. A lot of programs have treatment restrictions based on psychological functioning, cognitive functioning, and sometimes the medications that people are taking. And especially in substance abuse treatment, many programs will not accept people who are on benzodiazepines like Xanax or Valium. Others will accept it as long as they're being taken as prescribed and they're regularly urine dropped, and that urine is sent off to the lab to go through the mass spectrometer to make sure that their blood levels of the potentially addictive substance are within range for what they're supposed to be if they're taking the medications as prescribed. Sociocultural factors, including cultural differences, the role of stigma as it relates to whatever they're getting treated for, bias and racism from other clients, especially in group settings, from clinicians in individual or group settings, and just from the community, may also affect people's willingness to access treatment. Societal attitudes towards treatment and substance use. And here, again, as clinicians, social workers, case managers, whatever your position is, we can do a lot in terms of advocacy and education. People with addictions are people. They are trying the best way they can to survive, and stigmatizing them for trying to survive is not helpful. Stigmatizing them prevents them from wanting to admit they've got a problem and go to treatment. There may be disparities in health services for people who are of lower socioeconomic status and they can't afford $30,000 a month for residential treatment. Yeah. $30,000 a month and up is usually what residential is for a lot of facilities. Now, there are facilities that are state funded that do it for a lot less, but that's a whole different soapbox I can get on. And the attitudes of health care providers towards women or primary caregivers. If healthcare providers are more shaming of people who are primary caregivers, and they're like, how could you be drinking when you've got a 2-year-old at home? Or how could you that is going to definitely prevent not only that patient from accessing treatment, but word's going to get around that it is not a safe environment. It's important to really understand behavior as communication. What was that addictive behavior communicating? Was the person overwhelmed? Were they depressed? Did they need help? What was going on that was not getting met? Systemically, larger systems, including federal, state, and local agencies that generate public policies and laws, can be a barrier to treatment. The agencies that say, okay, you can get a bed in a state-funded program if you meet these 15 criteria, but not these over here. That can serve to block people from accessing treatment. Some local agencies or, like codes enforcement may not allow certain types of treatment facilities in certain locations. So we need to be sensitive to that. Businesses, including health insurance companies. Health insurance may not pay for substance abuse treatment, or generally they don't pay for enough substance abuse treatment. And environmental factors such as the economy and drug trafficking patterns may also serve as barriers to treatment. Treatment retention. We want to enhance family and significant other support through family treatment programs, through family education programs, but we also want to make these programs and services available as easily as possible, which means sometimes remotely, sometimes with, video chat, sometimes with videos and handout PDFs that can be downloaded that are on your website. Whatever methods you can use to make the stuff available to people in a manner that is as convenient and non-stigmatizing and non-threatening as possible. We need to encourage people to avoid relationships in treatment. People who are over 21 tend to have higher treatment retention. Well, think about it. Our prefrontal cortex is still developing until 24 or so, and a lot of our higher order thinking, cognitive processing, and impulse control takes place in that prefrontal cortex. So as people get older, as they have more experience, and as their brain develops, they may be more able to commit to treatment. People with more education tend to stay in treatment longer. And I wonder, I don't know, they didn't explain this, but I wonder if that's because people with more education may have jobs that actually give them paid time off. And people with less education, they got to get back out because every day they miss from work is money that they're losing that should be used to, put clothes on their kids' back or pay their bills. People who are involved in criminal justice or child protective services actually do tend to have greater retention because they've got something to lose. People who are pregnant often are retained longer because they know if they give birth to a child that is substance exposed, they're going to be involved in the system. And using a trauma-informed, supportive, strengths-based approach like seeking safety can also encourage treatment retention because we are recognizing behavior as communication and we're doing our best to create an environment that is accepting, empowering, and safe. We want to acknowledge the importance and role of socioeconomic issues and differences among people and promote cultural competence specific to women and primary caregivers. We want to recognize the role of significance of relationships in people's lives and address the unique health concerns of every person. We want to endorse a developmental strengths-based perspective, recognizing that the needs of a 17-year-old in treatment or a 21-year-old in treatment are likely going to be different than a 50-year-old or a 70-year-old. We want to attend to the relevance and influence of various caregiver roles that primary caregivers and people who identify as women often assume throughout the course of life. We want to recognize that ascribed roles and gender expectations across cultures affect societal attitudes towards primary caregivers who abuse substances. Everyone needs to have their basic needs, safety, and social support needs met. That hierarchy of needs. Basic needs, we need to have our bills paid. We need to have a roof over our head, food in our belly, and our medical needs met. We need to have safety. We need to have love and belonging. We need to have self-esteem. Women face some unique challenges based on sociocultural expectations, especially caregiving, and medical and mental health conditions that are more common in people who are biologically female. In response to Patricia's question about flare-ups of autoimmune diseases, yes, there are a lot of reasons that flare-ups may occur, but emotional stress is definitely one of them because when people are under emotional stress, that HPA axis is kicked off, which means cortisol, glutamate, norepinephrine, adrenaline, thyroxine, all of those excitatory neurotransmitters are released. inflammation tends to increase after the HPA axis is activated. As inflammation increases, that immune system that's already in wonky drive may also become more sensitive, more exacerbated. So you are probably going to see, or we do tend to see, flare-ups in both mental health as well as autoimmune issues when people are under acute stress and chronic stress. Alrighty, everybody. Thank you so much for being with me today. I hope you got something from this, and I will see you on Thursday when we are actually talking about some of the unique needs of children in foster care. So that's a presentation I haven't done before. I am looking forward to trying it out on you guys.